I would like to hit a couple things from my experience as a physician side of things, as far as the way that we look at the virus and the way that we would treat patients who would be of interest for potentially having the virus. It's important to keep in mind that this virus is transmitted through direct contact, through broken skin, or through mucous membranes with blood or bodily fluids, such as urine, saliva, feces, vomit, sweat, breast milk, and semen. It is not believed to be spread through air or through water. The incubation period, or the period in which one would be exposed and come down with symptoms, is ranging between 2 and 21 days. 21 days being the longest the incubation period would be. So when you hear about the 21 days coming from public health officials, what we're talking about is a period in which, after that, the likelihood of coming down with Ebola virus disease from a contact is exceedingly low. Most of our experience has indicated that the incubation period is between 8 and 10 days. The symptoms of Ebola virus disease include fever, headache, vomiting, diarrhea, joint aches and muscle aches. The basic interventions that you guys, I'm sure, have read about, but also would apply here, would include IV fluids, electrolyte management. There are no approved medications or vaccines for this disease, although there are some investigational agents that are being worked on currently. But as of yet, these have not been, their safety and the efficacy of these agents is not known. I'd like to turn it over to Julie Anderson at this time. I think there will be an opportunity for questions at the end. I'm sure that we'll work to answer those to the best of our ability. Thank you.
Thank you, Dr. Sullivan. My name is Julie Anderson. I'm Community Health Services Director. And the first thing we want to say is that early detection is key. We found that the folks, anecdotally, that have sought treatment early are doing better. So our answer to that, and what we've been directed by the Department of State Health Services, is that if you're a known contact to a case, and we've all heard about somebody who's been quarantined for the 21 days, that it'll be the health department, nursing staff, and Mike Paulus's EPR staff that'll be doing that contact investigation. This is not new to us. We do this really every day with tuberculosis. And we work with concentric circles that work outward. So you work towards who was nearest the patient, and you keep working out till you stop disease. And then part of the temperature monitoring is we would been directed to monitor temperature 2 times a day of known contacts, with one of them being observed by someone on staff here at the health department. One of the ways that the nursing division is supporting Dr. Sullivan and all the area hospitals and doctors' offices is if they have a sample that needs to be sent to the Department of State Health Services lab in Austin, they can call the health department, help get approval and the shipping requirements to get a patient sample from here to both us in Austin and to the CDC. So anybody needing that, and all the hospitals have been briefed on that as well. And again, the contact investigation is important. So if people recognize who've been in contact with the virus and are running fever and have the symptoms, encouraged to call the ER first and give your health history. Say, I feel that maybe I've been exposed to the virus. Here's my name, here's my contact, and ask who answers the phone how they want the patient to present. Do they want you? What entrance do they want you to come through? And that way they can meet you and be prepared. The same thing with calling 911. If you feel that you need to call an ambulance for transport to the ER, mention it to the 911 operator that I feel like I've been exposed to the virus, so that they can be getting ready. It just helps everybody kind of get on board, and also takes that level of fear down. One of the things that we wanted to go through today is fear is our worst enemy in this, and we don't want to make it more than it is, and we do not want to make it lighter than it is.
Things we're trying to do is we're trying to make sure that the teaching points are out there for local emergency services, the emergency rooms, the hospitals, and other individuals that serve as first responders, either volunteer or full-time paid, going all the way to the realm of funeral home directors. I mean, we've got to anticipate that there's going to be a lot of people that are involved if and when Ebola occurs in Brazos County. I'd like to point out, though, we have several hundred people that have been exposed to Ebola, but we've only got 2 active cases, 2 people that have come down with the disease. So right now, and I've said this on previous newscasts, that you have a better chance of being hit by a meteor or by being hit by lightning right now than you do of coming in contact with Ebola. We can't take the chance, though, that's not going to happen. So we have to put the education out there. I gave 7 briefings yesterday, 5 of them to the Bryan Police Department. Bryan PD has advised me that they have transferred information to the 911 district, and 911 has been apprised of what to ask if somebody is complaining that they have the disease, because yes, they've gotten several calls that we've got all kinds of things that are being called into us where people are reporting they have Ebola. One I would like to make really, really clear, the Ebola dog is not in Brazos County. I've got 5 calls yesterday that the nurse's dog was being cared for at the vet school. It is not. It's in the Dallas area at a former Naval Air Station, and they are being advised over the phone, the Dallas area, by the vet school. It is not here in the county. We have no Ebola virus within the confines of Brazos County at this time. So we're trying to schedule meetings with everybody who's in the chain that requires knowledge to be able to operate safely if the virus does occur in our county. We want EMS, fire departments, law enforcement to be comfortable with the material so that they can approach situations from an educated perspective, and we want to make sure the emergency room and hospital staffs in general are protected, because since we're seeing healthcare workers be most affected by this, that's not acceptable. Healthcare workers, first responders, no one in the chain that's actually trying to help is expendable, and we're trying to do everything that we can to make sure that they do not contract the disease if it does in fact show up here. We've changed one protocol, and that is that when they came out of the treatment area up at Presbyterian Hospital, they merely dry doffed their personal protective equipment. We are recommending that wet decontamination be done. In other words, they're sprayed down with an antiseptic solution, or excuse me, antibiotics, or what am I trying to say? A solution that kills viruses, bacteria, and what we're going to do is we're going to kill the virus before you have a chance to come in contact with it as you're taking your personal protective equipment off. With that, I guess we turn it over to questions. We will be, we've got a very close working relationship with both the Bryan and College Station school districts. Yes, there are other large organizations that could benefit from having this knowledge. We won't turn anybody down if they request training or for that matter, just a short briefing. We have not had any interaction with Easterwood at all yet. That is coming, but because of the fact that there's so little supervision of people that are leaving the planes, and we don't have the giant airliners coming in here. It's really hard to monitor the people that are coming off. And right now, the big thing is if we do have somebody that has a travel history, and that's the thing that we're asking the first responders to ask about is their travel history. Have they been to Africa? And secondarily, maybe have you been to Dallas, around the area of concern? That's one of the things we need to know about, because that's going to raise our level of suspicion up a little bit more, and we're going to be a little bit more careful. Some folks are concerned with what they can do to protect themselves at home, and I'd like to say that the virus that we're dealing with is no more robust than the cold virus, the flu virus, or for that matter, HIV or hepatitis C. Common disinfectants, Lysol wipes. I'm not trying to sell any particular brand here. I'm just trying to say what you can find on the store shelves or alcohol hand sanitizer will kill the virus. So if you have concerns at home and you want to take extra precautions, just use the common disinfectants. I remember the word this time. Common disinfectants that you can find at any of the local supermarkets or for that matter the convenience stores, and that's fine for disinfecting just about anything that you'd want to be able to cleanse. So again, you can protect yourself by staying clean and making sure that, that especially food surface areas where you're preparing food, they stay clean, and pay attention to your hands and make sure you're cleaning your hands regularly. If not with soap and water, everybody's got hand disinfectant on the walls now. Take advantage of them. Thank you.
There is a very important piece that Mike mentioned that I think needs to be emphasized, re-emphasized, is that the virus is most communicable, most transmittable, most contagious when someone is very, very ill. Okay, so I want you to imagine somebody who is, as they're becoming more and more ill, becoming more and more contagious. And the reason why that's important is that for someone who is not sick, someone who does not have symptoms, that person is not contagious. So to answer your point about the hysteria and some of these questions that come, I think that if we understand how the virus works and transmits, that can really allay a lot of anxiety there. Walking through an airport or walking through a crowded area where somebody from even one of these countries, Liberia or one of these West African countries or somewhere where they've traveled that would be at a higher risk area, if they are not sick yet, they're not going to be contagious to a person who is a casual contact. The two secondary cases that we have thus far are nurses who were very involved with a very sick patient, and it's very important that we keep that in mind and that everyone keep that in mind, because this is the way that it is transmitted. And we see this as our experience. We've known this from the way this virus has been transmitted in West Africa and our previous experience with outbreaks. And so I think it's important that we keep that in mind. But yes, we do get questions. There might have been somebody who might have been from one of these countries, and I'm getting a cold. All right, well, this is the cold season, and we're coming upon the flu season, and common things are common. It is much more likely that you're going to get a cold, that you're going to get a flu. And we need to be getting our flu shots, and we need to be doing the things that we always need to be doing for our health. But to get this disease, you need to be in contact with someone who has the disease and is sick. And that's what we're trying to outline from folks when we do our screening processes, is to find out at what risk are you. Because if you are at one of these high risks, and for the most part, 99.9% of people will not be in that scenario, but we're very interested in that very small percentage who may be. And in those situations, we're looking for those who are at a high-risk contact and are ill. And those are folks who we will watch very closely and possibly set up for testing in collaboration with the health department. And so the medical facilities here in town are in coordination with the health department, which trips a much larger cascade of public health involvement to make sure this is done in a coordinated fashion. This is the first time that Ebola has been on our shores in this fashion. There's been other viruses similar to this that we've been through a similar experience. But Julie made a point earlier that we are working within the infrastructure that we use here for more common things, such as tuberculosis. And at times, we've had to do this when there are other viruses of interest or other infectious agents of interest. This will be the first time, of course, that we've dealt with Ebola in this regard. But we're using methods and we're using practices that we've been using for decades to work with this. We are learning about the best way of doing that, clearly. And we've made some mistakes along the way, clearly. But it's a novel situation, and we are quickly learning about these mistakes and correcting them so that we can, as Mike had mentioned, be as safe as we can through everyone who would be in contact with the patient. We are learning much as the public is learning, because this is as things come out through media outlets, essentially. We do conference calls with folks, with representatives from the CDC. I know that as of my last conference call, I was involved in that we still don't know all of the potential breaches, so to speak, if there were one, with personal protective equipment. But of course, that's the concern. And so we take that very seriously to ensure that we are training healthcare workers here in the Brazos Valley to ensure that personal protective equipment is put on properly and taken off properly. It's very important that, and also, as Mike had mentioned, what's called a wet decontamination, where the personal protective equipment becomes decontaminated with a virucidal solution that does kill these viruses, that makes it more safe to take off the personal protective equipment. And so these are some of the lessons that we've learned, although I would say that at this point I am not aware of exactly what it is that led to the secondary infection, which was not expected. And I know that they did the best that they could do in a very difficult situation, and unfortunately we all have to learn from that situation. But it was I feel for all involved, because that is as difficult as it gets, to be in that situation. And they're very brave in the way that they went about treating this patient. When we're talking about droplets, allow me to be a little bit truthful about what this is. Basically snot, so to speak, right? So it would be a droplet of secretions that would be coming from our nose, from our mouth, from coughing, that would travel, we think, at about 6 feet radius. Okay, that is a droplet. Okay, now keep in mind, this is a sick patient who would have virus to shed. So that is what a droplet is. Airborne are agents that can actually suspend in air, hang out in air, and can be then breathed in later. Now, it's important to keep in mind that very, very sick patients who are in ICU, critical settings, by the nature of what we have to do to keep this patient alive, with intubation, for example, or suctioning, that can aerosolize things. It can aerosolize these agents in the air. All right. However, it is not. That is a very special situation, and we are taking, we would be taking very high-level precautions in those situations. However, for those out in public, or those in airports, or those, we would not expect that at all to be occurring. It is possible that, as I said, that some of the nasal secretions or saliva that someone will be coughing could be expelled further than that person's body. Then 6 feet is kind of the radius that we use for that. But again, this would have to be a sick patient with Ebola who was expectorating this. So that's the difference between a droplet and between airborne suspension of particles. We do not know this to be airborne, and it is not airborne. We've done multiple studies on this. There's a lot of good data on that. We've known about this virus for decades, as we've mentioned before, and as we've read the CDC. And so it does not act that way. It's not transmitted that way. So it would really have to be droplets into mucous membranes of someone else. I think one would remember that encounter. It would not be pleasurable by any means. So we're learning about how this virus is transmitted. One who would be in direct contact with bodily fluids of a sick person, we would certainly take that. I mean, even if they didn't have cuts, that person would be of interest to ensure that they did not come down with this disease. So what I would say is less likely than, of course, if it was open or if it was in a mucous membrane, but still likely enough that we would consider that person of interest to ensure that they don't come down with the disease. So we're still learning about exactly the way that the virus is transmitted with multiple other viruses as well. But for this particular virus, we do take that seriously. If one were to be around or have direct contact of a bodily fluid onto the skin of a sick patient with Ebola. I would say that we need to ensure we're using common sense. The most likely thing, of course, to acquire traveling would be the common cold or to acquire the flu. And all of these viruses are killed by alcohol-based hand rubs. The there is absolutely no reason to think that an airport is not safe. There are, within the confines of the travel and what we would be doing, those who in the United States are being investigated right now, I think we've learned shouldn't be traveling, in that 21-day window, as we've learned, again, from this past experience. But I would say that we would be smart about that, using good hand hygiene, and there's certainly no public health authority right now who would be recommending to not travel. That wouldn't be in line with the science, and wouldn't be in line with our experience thus far. It's difficult to, they're having difficulty, in particular in Liberia, from what I've read from WHO reports, in getting case numbers. And I think one could very easily see how difficult this could get in a hurry, to try to keep counting. Some folks might be at home with Ebola. They might not have come in for treatment. Those who did come in with treatment, are all of those getting reported up through the proper agency? So I believe that's where that's coming from. But there is a concern that there might be more than the numbers that we see. If you look on CDC's website, on the Ebola link off to the right, there's a banner there that will have case counts. And of course, that's, if anything, thought to be an underestimate. It's not known how much of an underestimate that would be, but it's thought that there may be more cases there. We just have not yet either identified or through the usual notification techniques that are there, which of course I'm not qualified to speak on because I'm not there and seeing how it's all being done. But that's the concern, and so that there are more than have been reported in these West African countries. I can say that with confidence that folks are working on it rigorously, that both the government and industry are working together, the Department of Defense. So lots of folks working on this who do this for a living, but I have not seen, and I don't think anyone knows really what that timeline is. Of course, people are working on it very quickly, very rigorously, to work to get this out. It's one thing to get a product, but then we need to know, is it safe and is it effective? And so there's that other piece. And there are some products, as you all have read about, I'm sure, that are investigational and have been used. It's not known if that worked, if it was the early treatment that Julie was mentioning before, the early detection and fluids and that we use. We're learning much about this virus and about the way that it responds, the way our bodies respond to it. But I do not know that timeline. I do know that folks are working on it around the clock. They're working on it, both a treatment and a vaccine.